Hello everyone, welcome to sqadia.com, and now we will start our section 3 of the lecture topic acute pelvic infection, in which we will talk about the investigation and treatment of pelvic inflammatory disease. In this section, we will talk about some diagnostic criteria and investigation of pelvic inflammatory disease. What's the differential diagnosis and complications of pelvic inflammatory disease, and what's the treatment of pelvic inflammatory disease? So diagnostic criteria we divided into minimum criteria, then some additional criteria, and then what's the definitive criteria for the diagnosis of pelvic inflammatory disease. So minimum criteria that should be present for the diagnosis of PID or pelvic inflammatory disease is the lower abdominal tenderness, adnexal tenderness, and cervical motion tenderness. So that's the minimum criteria. Usually patients who have pelvic inflammatory disease, they complain of pain in the lower abdomen, and when we press or when we palpate, there is tenderness in the lower abdomen, and there is tenderness on the motion of the cervix on the pelvic examination. Then some additional criteria is there is oral temperature, which is usually above 38.3 Celsius. There is mucopurulent cervical or vaginal discharge. Then there is raised ESR or C-reactive protein on the lab testing. Then also there should be lab documentation of positive cervical infection with gonorrhea or chlamydia trachomatis. So this is the additional criteria for the diagnosis of pelvic inflammatory disease. Next, some definitive criteria. If there is histopathological evidence of endometritis on biopsy, then it's the definitive criteria that there is pelvic inflammatory disease present. Imaging study, which is MRI or transvaginal study, which shows the evidence of thickened fluid-filled tubes, or there is tubo-ovarian complex, or there is laparoscopic evidence of PID. So on laparoscopic examination, if there is evidence of pelvic inflammatory disease, that's also the definitive criteria. And same if on MRI, then it's again definitive criteria. So these are the three criteria on the basis of which pelvic inflammatory disease can be diagnosed. Then some investigations that can be performed for the diagnosis of pelvic inflammatory disease is first is the identification of the microorganism, and this is usually performed by the collection of the specimen and then by the smear that can detect the microorganism that can cause the disease. So materials are collected from the discharge from the urethra or Bartholin gland, from the cervical canal, and then from the fallopian tube during laparoscopy or laparotomy. And then these specimens are tested for the microorganisms that are causing the disease, and then the treatment can be started against those microorganisms. Then the other test that can be performed is the sonography. In the sonography, there is usually dilated fluid-filled tubes, and there can be a fluid in the pouch of Douglas, or the other thing that can be seen on ultrasound or sonography is the presence of the adnexal mass. Then leukocyte count. Leukocyte count is the count if it's more than 10,000 per cubic millimeter, it's usually an indication of infection present. Leukocytes are the white blood cell. White blood cells are the cells that fight against infections. So if the white blood cell is high, count is increased, it means infection is present in the body. An elevated ESR of more than 15 millimeter per hour is also indicative of infection present. ESR is erythrocyte sedimentation rate. Erythrocyte sedimentation rate, the rate at which red blood cells or erythrocytes settle in the tube. If it's more than 15 millimeter per hour, it's also an indication of infection. Then another test that can be performed is culdocentesis. In culdocentesis, the fluid is aspirated from the peritoneal cavity, and if the count is more than 30,000 per ml of the cell count, white cell count, it's also diagnostic of infection. Some gold standards for the investigation of pelvic inflammatory disease is divided into mild, moderate, and severe. In the mild form, usually there is edema, erythema, or purulent exudates present from the tubes, and the tubes are usually mobile, they are not fixed. In the moderate form, there is purulent exudate or exudate, which are the excretions which has the pus in it. That's the purulent exudate present from the ends of the fallopian tubes, and they are not mobile, they are fixed, and they have scar tissue present. In severe form of usually there is pyosalpinx, means pus present in the tube, and there are abscess formation also. Then violent strings like adhesions are present in the pelvis and around the livers, which suggest the chlamydial infection. So if violent strings are present, that's the indication of infection caused by chlamydia trachomatis. Now the differential diagnosis of pelvic inflammatory disease or differential diagnosis of acute salpingitis, which is the infection of fallopian tube, from acute appendicitis, which is the infection of the appendix, and then from the ectopic pregnancy. Because these are some very commonly associated conditions. Sometimes acute appendicitis is confused with acute salpingitis, and also complicated ectopic pregnancy or presence of ectopic pregnancy is also sometimes be confused. So some signs and symptoms that helps us to differentiate between three commonly associated condition is, first, the pain is present in all three types of conditions, but the difference between the area is important and what type of pain is present. So pain in acute salpingitis, the pain is usually in the lower abdomen on both sides. On right and left, in acute salpingitis, pain is present. In acute appendicitis, pain usually starts from the umbilical region and then it goes to the right iliac fossa. Then in the ectopic, usually acute lower abdomen in one side. So it's an important differentiating point. And salpingitis, it is present on both sides. In appendicitis, it is present in the right iliac fossa and start in the area around the umbilical region. And in the ectopic pregnancy, usually it is on the one side. Then the other differentiating point is amenorrhea, which is absence of bleeding or a menstrual cycle and bleeding per vaginum. Usually in salpingitis, it's not present, so it's unrelated. Same in acute appendicitis, it's unrelated, but in ectopic, usually it is present. GI symptoms such as nausea and vomiting, again, salpingitis is inconsistently present, but in acute appendicitis, nausea and vomiting is usually present, but in ectopic, it's absent. General look of the patient in salpingitis, patient has the flushed face. In acute appendicitis, it's toxic, and in ectopic, again, is the pale. So flushed in salpingitis, toxic in appendicitis, and pale in ectopic. Tongue. No significant change in salpingitis. In acute appendicitis, usually the patient tongue is furred, and then in ectopic, usually the tongue is pale. Pulse. Pulse is rapid, but it is proportionate with the temperature. If temperature or if fever is high, the pulse is usually very rapid and fast. Tachycardia, which is the rapid pulse, is present in patient with high fever. Again, in appendicitis, it is proportionate to the fever. And then in ectopic, there is persistent rise even with the normal temperature. That's the difference in the pulses of the three conditions. Temperature, it's raised in salpingitis, slightly raised in appendicitis. It is not raised in ectopic. Tenderness, lower abdomen on both sides. On McBurney's point, may have muscle guard. So if it's in the appendicitis, it's a very important diagnostic feature of appendicitis that once you percuss or push the patient or palpate deeply and then leave the area, the patient has the rebound tenderness there. So that's important diagnostic sign of the appendicitis. Then in the lower abdomen on the one side. Per vaginum, what are the changes? There is tenderness on both fornices. Mass may be felt in salpingitis. There is tenderness on right fornix and high up, and then there might be mass felt through one fornix extending up to the pouch of Douglas. So these are some differential diagnoses, how we can differentiate between three very common conditions that can be confused: acute salpingitis, appendicitis, and the ectopic pregnancy. Next, some complications of pelvic inflammatory disease. They are divided into immediate complications and late complications. The immediate complications are peritonitis or pelvic peritonitis or generalized peritonitis or septicemia, which can lead to arthritis or myocarditis. Arthritis is inflammation of the joints, and myocarditis is the inflammation of the myocardium of the heart. Then late complications are dyspareunia, which is painful intercourse. Infertility. Infertility is very, very common in patients with pelvic inflammatory disease. Then chronic pelvic inflammation due to recurrent pyogenic infection is common. Formation of adhesions or hydrosalpinx. Then there is chronic pain and ill health. And there is increased risk of ectopic pregnancy. All these are very common complications of pelvic inflammatory disease. Next, treatment. Treatment of pelvic inflammatory disease is divided into inpatient, which are the hospitalized patient, and then outpatient, which are the patient which are not hospitalized. Inpatient usually which are in the hospital, we can give them the IV antibiotics so they can be monitored and better. So inpatient treatment is divided into regime A and regime B. In regime A, cefoxitin 2 gram intravenously, IV is intravenously every 6 hours for 2 to 4 days. Also, along with cefoxitin, doxycycline 100 milligram orally for 14 days. In regime B, clindamycin 900 milligram intravenously every 8 hours plus gentamicin 2 milligram per kilogram IV intravenously is given every 8 hours. Alternative regime besides these, we can also try levofloxacin 500 milligram intravenously and metronidazole 500 milligram intravenously. So inpatient, if you can see, are treated more with the intravenous therapy. Ambulatory or outpatient are usually treated again. Regime A will be levofloxacin orally for 500 milligram orally once day, or along with metronidazole 500 milligram orally 2 times a day. PID is 2 times a day. PO is per oral by mouth. In regime B, we give ceftriaxone 250 milligram intramuscularly in a single dose, plus doxycycline 100 milligram per oral 2 times a day with or without metronidazole 500 milligram. So these are the two main regimes. One is for inpatient, one is for outpatient or ambulatory management. Next, what are some indications for hospitalization of the patient with pelvic inflammatory disease? One is suspected if there is suspected tubo-ovarian abscess, severe illness, vomiting, temperature more than 38 degrees Celsius, uncertain. As we mentioned before, some common conditions that can be confused with pelvic inflammatory disease or salpingitis is appendicitis or ectopic. In both these conditions, if appendicitis is suspected, sometimes emergency surgeries are recommended or required. So in that case, hospitalization is important. And unresponsive to outpatient therapy for 48 hours, if there is intolerance to oral antibiotic, if there is coexisting pregnancy, if patient is known to have HIV infection. All these are the indications for hospitalization of the patient. So that was all about the management and treatment of pelvic inflammatory disease. Thank you for watching sqadia.com.